I'm Jane Clark. I'm the Dean of the school, if you weren't here at 8:45 this morning. But it's my pleasure today to introduce our person who's going to introduce our speaker. This is the way conferences always work. Dr. Olivia Carter-Pokris, who is a professor in the Department of Epidemiology and Biostatistics, will introduce our guest speaker. Okay, there you go. No, I didn't. I could have said teacher.
Yeah, thank you, Jane, for the promotion. But I'm very pleased to introduce Dr. Georges Benjamin. Some of you may know I've had the opportunity to serve with him on the executive board as well as on the science board and the education board. I'm back again on the science board. But some of you may also not realize that I traveled with him to Israel as part of a delegation of public health. As part of that. So it's my pleasure to introduce him as our afternoon keynote speaker. He served as the executive director of APHA, the American Public Health Association, since 2002. Many of you are members and active in that organization. He joined from his position as secretary of the Maryland Department of Health and Mental Hygiene. As secretary, he oversaw the expansion and improvement of the state's Medicaid program. He's a graduate of the Illinois Institute of Technology and the University of Illinois College of Medicine. He's board certified in internal medicine and a fellow of the American College of Physicians. He's also a fellow of the National Academy of Public Administration, a fellow emeritus of the American College of Emergency Physicians, and an honorary fellow of the Royal Society of Public Health. He's a member of the Institute of Medicine, of the National Academies. He also serves on the boards for various organizations, including our own University of Maryland Medical System. He's been named one of the top 25 minority executives in healthcare by Modern Healthcare magazine, and among the 100 most influential people in healthcare. Please join me in welcoming Dr. Benjamin.
Olivia, thank you very, very much. And good afternoon, everyone. And I'm just really excited about being here. I'm going to talk a bit about a lot of the issues I think that are going on right now in terms of our quest for health in our nation. I always like to remind folks that we've been at this quest for improved health for 100 years or more. This is an early cartoon actually from a book that we did on health reform using political cartoons to talk a bit about the fact the nation's been trying to do this for some time. And then, of course, this is the epic signing of the Affordable Care Act by the president in March of 2010. So I also like to just talk a little bit about what is health, and I always like to use the World Health Organization definition of health just to point out that it is certainly not just the absence of disease, but a range of other things around quality of life that makes people really healthy as we understand health today. Also, to remind you that I'm doing what I always do is conflating public health and population health. I'm always confusing those two. I use those two terms interchangeably, but the truth of the matter is that they're not interchangeable. The population health is something quite different. I like David Kindig and Greg Stoddard's definition of population health because I think it's a useful definition. And as we begin talking to our colleagues on the clinical care side of our system, this definition actually does work for them as well because it really talks about trying to improve the health of groups of people from 2 to millions. And I just think it serves us very well. We use population health. We use a range of tools to try to improve population health. And of course, you know these tools and you use them every day. Either you teach them or you use them in your research. But I just point these things out that these are really fairly unique tools. You don't see anything on that list that talks about opening up a chest or catheterizing an orifice. Or making your new orifices, which we often did in the emergency department to put things into people. These are really amazing tools that we need to use, particularly things around public policy as a health improvement tool and community engagement. Population health does not work without engaging the community. We're concerned about all this because our nation is not getting the best value for our healthcare dollar. Now, I want to point out that if you get sick, this is where you want to get sick. I mean, we can put us back together better than any place else in the world. We do this quite well. But as compared to the rest of the nation and the rest of the planet, and particularly the other industrialized nations, we don't do as well. We die sooner, and the real challenge here is that in many cases almost twice the cost. And so that's what we're trying to do. Several years ago, Mike McGinnis and all looked at what are some of the root causes of early mortality, and they recognized that this very famous Venn diagram that everyone uses right now, this pie chart that talks a bit about all the other things from a proportional perspective which work to make us healthy, recognizing that health care itself is only about 10% of that equation. If you get sick, it's a very important 10%. It may be 100% of what's actually going to do something for you. But long before we get to the doctor's office, all these other parts of this pie chart are very, very important to us. And again, you know that as part of the work that you do every day. I often get in this debate with people about access to health care because I think about access to health care through a population-based lens. The fact that health is certainly about access to care, but it requires superb health care providers that are willing to provide that care. In our nation, health insurance is the primary means by which almost everyone gets their insurance coverage. We know that 44,000 people die prematurely each and every year simply because they do not have health insurance. And while we have an amazing safety net system of clinics and charity care and emergency departments, they're not a substitute for having to get into the system card. I don't care what charity care system you go into. Once you've taken care of, the next person that needs to provide care for you, the first thing they're going to ask you is, what is your insurance and do you have an insurance card? And that's one of the real challenges that we have as we think about how we want to improve this care. I also point out that having insurance actually does make a difference. This is examples of mortality rates when they've been looking at that for Medicaid coverage. Medicaid always gets bad-mouthed as not being good coverage, and we always have big issues around Medicaid coverage, mostly because of what we pay providers, which is totally inadequate. But we see very clearly here that when Medicaid coverage goes up, mortality goes down. And this has been repeated no matter where we are in the country, no matter who's done that study. Even Medicaid coverage, quote unquote, reduces mortality because it improves your health and your access to health care. So fast forward to the Affordable Care Act. This is basically, the Affordable Care Act often gets described as complex. It's not real complex. It really is about insurance reform and health system reform. And these are the core buckets that the Affordable Care Act basically takes care of people. The goal is to try to get more people covered, provide better benefits and more protections to lower costs overall, which, by the way, it's been very successful in doing for both the system and many individuals, not everyone, but for many individuals, to begin to improve the quality and efficacy of care and to provide a stronger workforce. There are lots of provisions which have not yet really been implemented around workforce and the infrastructure. And then there really is a bunch of stuff in that legislation around creating a focus on public health and prevention that we think are very important. And at least from a coverage perspective, for sure, the AC has been very successful. This is the last great chart that I've seen on coverage of the Affordable Care Act. You can see the peak after 2013, we were at 18% of our population without health insurance, and it's now down to somewhere around 13% or so. These are Pew and other surveys that are done. I think this one is done by Gallup. But everybody who's looked at this has been somewhere in that ballpark in terms of the number of people that now have coverage under the Affordable Care Act. So as a coverage vehicle, it's been very successful. Yeah, you go ahead and give a clap for that. But health is much more than health care. We know that health is about things like place. Place matters. And I just want to raise your awareness, if you haven't had that, as I get older and closer to retirement, 10 or so years from now, I'm beginning to try to figure out now where I can live that will try to help my longevity. And as you can see, where you live matters, and relatively significantly where you live. This doesn't say a lot about quality of life, but it does say a great deal about where you live and how long we live. And you can come up with all kinds of reasons why people in Florida, maybe all the healthy people went down to Florida, or all the healthy people went up to Idaho, who knows. But there are reasons for that. But there are also differences in mortality that are close to us. So this is, those of you who know the Washington metropolitan area know this is a representation of the Metro map. And you can see that the average life expectancy in the District of Columbia is around 72 years. And depending on how far you are out and where you are out from the center of Washington, D.C., you will live longer. I'm always excited about the fact that, again, just because I'm living up in Gaithersburg, Maryland, I'm guaranteed 81.3 years on average. I do that when I'm eating unhealthily and just trying to rationalize what I'm doing. You know, the real challenge we have is that my drive from Gaithersburg in the morning can be 30 to 40 minutes. And to have such a phenomenal difference, almost a 10-year difference in mortality, a 30, 40-minute car ride. And if I'm doing mass transit, which I'm supposed to, even faster. This is an amazing difference. As you know, 2 or 3 years of mortality is a big deal from a public health perspective. So this is important, really, for us to understand. And you know, one of the things is when you start looking and you overlay this kind of thing on the new county health rankings that we have, you see people's county A next to county B with enormous differences in their county health rankings, enormous differences, not just in mortality, but a whole range of health outcomes. Again, in many cases, most of that stuff is preventable. This is the Minneapolis and St. Paul, Minnesota area. Again, just a few miles different. So look at this, look at the difference in 2 to 4 miles along this one highway. Enormous differences in mortality, okay, in mortality. So it makes a big difference in place. And we have to better understand all of the parameters of why place matters so much in our nation. We know that health is about risky behavior. Certainly, tobacco still remains the leading preventable cause of death, with over 400,000 people dying each and every year prematurely because they are smoked or in many cases been exposed to tobacco smoke. We still have too many of our people who smoke who start smoking in early adolescence. It costs all of us, all the people that say, well, I don't smoke, so it's not a big deal. It is a big deal because you're actually paying for it in a variety of ways. And we know that there are solutions throughout our system to try to deal with this. I still consider tobacco as public enemy number one, and still believe that this is an important way for us to try to improve our health. But tobacco is just an example of the many kinds of risky behavior that we have. We know that health is about equitable access to affordable, nutritious foods, that we can address this by dealing with this issue of food deserts and zoning. I was just up in Trenton, New Jersey, saw an amazing experiment where they're incentivizing small grocery stores, and what they're basically buying them are chillers so that they can offer fresh fruits and vegetables in their store. They cost $1, $2 for these little fruit cups, and the store is making money, and they're flying off the shelf. You know, all the people that tell you that poor people won't buy fresh fruits and vegetables, they're wrong. They're just wrong. New York City has a green card experiment where they expanded the number of those corner vendors. Now, whether or not, you know, the corner vendors in New York, we all love them. Whether or not the food they serve is healthy is as the food's dripping, the grease dripping on your shirt, is questionable. But they decided they would expand 1,000 new permits, but only if those carts sold fresh fruits and vegetables in areas where there was a food desert. Food desert being defined around fresh fruits and vegetables. And those folks are making money, and those communities now have access to fresh fruits and vegetables. I was there 3 years ago, and it seemed to be going gangbusters. I don't know how it's going today, but other communities have tried to adopt this concept. Some of them are putting trucks in place where you can drive in the community, refrigerated trucks to offer fresh fruits and vegetables. There are many ways to try to skin this cat, to try to improve access in the communities. It's clearly about what we eat. I know that we demonize the sodas as calorie dense and nutritiously low. And I like my soda just like anybody else, but it's about how many of them you drink. And clearly, this is a big issue that we need to, again, do better education of folks so that people will change their diets in a variety of ways. Health is about external and internal stressors. And there certainly is both an issue where things are focused on the individual. There are population-based component to that, violence on the movies, certainly can stress people when they see this violence. But I got to tell you, people's assumptions about who they are and what they are. We've seen tragically in our nation over the last several months just a gross demonstration of racism and discrimination in a variety of settings. And we're having this big national debate, which we ought to have. But it's a big deal, and it shows itself in a variety of ways. And people will say, well, I'm not a racist, and I don't discriminate against anyone. But when you see their behavior, provider disrespect or they're biased. And when I go shopping, I can tell you that I watch how I'm dressed and what happens when I go in the store. And sometimes I'll go in the store kind of dressed down and, watch them follow me around the store. And of course I enjoy it. So I go out and then come back in so I can enjoy that experience again. But it's a challenge. It's a challenge for people. And they don't know they're doing it. We all have our inherent biases. Practicing medicine, assuming that someone comes in, doesn't have insurance, assuming that they're illiterate, assuming that they're not going to take care of themselves because of what you visually see about them or your poor understanding of who they are as a person. We have to deal with that in terms of the stress that we provide to others. And of course, a whole range of things around how people accept this, This is the concept of their ice is colder than my ice concept. We usually use other words when we use that term. But it's true. The idea of people's self-evaluation of themselves, the helplessness and hopelessness that occurs, which frequently pushes issues around substance abuse. I mean, one of the arguments, of course, is why people continue to do that is they're trying to cope with the day. They're self-medicating. They're trying to deal with this. And in some cases, they are committing suicide each and every day by their helplessness and hopelessness. And we need to begin dealing with this. We need to get away from blaming the victim and creating systems that provide aid and assistance, recognizing that every single one of us gets up every day and has challenges in that day as we move forward. We know that health is about ensuring safe water and safe food. We know it's about air quality. I know you just had a big presentation this morning about climate change. We're beginning to understand more and more about the impact of the fact that the freeways go through our poorest communities, and there's a strong correlation between chronic obstructive pulmonary disease and asthma in many of those children. We know that the risk of dying for a variety of diseases increases in many of our communities because of the way we've designed those communities. And we need to pay a lot more attention to that as we go forward. We know health is about where we dump our trash. And I remember a very famous example of this. I just become a DC health officer, and actually some of you may know Reed Tuxson and I were kind of sharing the job. And we used to have these big trash haulers that would come across the 14th Street Bridge. And they would turn right. And those of you know what I mean by turning right means they go into the poor part of town, Ward 7 and 8, where there were a lot of vacant lots and dumped their trash. There were also vacant lots in Georgetown, but for whatever reason, they never turned left and went over there, but we'll figure out why that is later. But they would dump their trash. And one of our public health interventions was putting police officers on the bridge to either arrest or turn those trash haulers around. And we see that. We see that as a big issue. Where we dump our trash is very important. And I think as a nation, we need to spend a lot more attention to this as we go forward. We know that health is about access to quality education. It is very clear. These data has been shown, and everyone that has looked at the relationship between infant mortality and the mother's education has shown that higher education, lower infant mortality rate. It occurs in the United States. It occurs in any place on the planet that's actually done this study. We don't know what maternal education is as a surrogate. I don't think really anyone understands all of the aspects of that, but the correlation is clear. Education makes a big difference. I talked about the importance of building and planning our communities differently. You know, again, imagine communities which were all walkable, bikeable, and green, where we actually sat down and designed communities through a health lens, in addition from other kinds of planning lenses. The American Public Health Association is partnering with our good colleagues at the American Planning Association. And we've got our affiliates and their affiliates in targeted communities looking at how we can jointly work to try to improve the planning process in our communities so we build our communities quite differently than we build them today. It's about where we place our schools. So I guess you got to ask yourself, which one of these schools would you prefer to have in your community or have your kids go to? Do you really want to go into a school where you got to put them in the bus and drive them, adding more fossil fuels in the air, where kids cannot walk to school or cannot bike to school, or you can't get to school and be involved with your kids? That's one of the real challenges. And so as we begin to think about, again, bringing people back to the central cities, redesigning new communities, we want to start thinking more and more about making sure, again, as kids go to school, that we reduce their commute time and give them walkable, bikeable places which are much safer than taking them and putting them on the bus. And I got to tell you, even when we do so, far too many of our communities, as you know, we have places where the kids can see the school, but they can't walk to the school because it's not safe. It goes across a 4-lane highway. There's a range of reasons that prohibit those kids from being able to get to that school. It's about places to play to help address sedentary lifestyle. One of the tragedies is that we pulled gym and physical activity out of school. We know that children that are in organized play do better in school. They have better mental health. They do better physically. They're able to study more. Those of us of my age remember that time out in the playground was fun. Sometimes we got in trouble, but in general it was fun. In many cases we didn't get in trouble in the classroom because we were able to burn off some of that energy. We were able to focus ourselves. So I think it's more important that we do this. By the way, we have huge arguments with people about this. They think that we shouldn't spend health dollars about building these places to play. We had this big debate with Congress about the Affordable Care Act and the Prevention Fund because some communities were putting in, using the fund to plan for playgrounds and do that kind of stuff. I got to tell you, it is cheaper to have kids with good mental health who stay out of trouble with good physical fitness than to spend the criminal justice money taking those kids through the criminal justice system. So I would much rather build playgrounds than jails. We know that, thank you. We know that health is about transportation systems. We know that building mass transportation is very important. Actually, when you have mass transit in the community and people use it, they actually walk. You know, they drive to the lot, but then they have to walk to the bus, and they have to walk from the bus or train, and then they have to walk from there to the office. So they actually improves people's ability to be less sedentary if we do that. We know that health is about equitable access to quality housing. This is a big point because we really haven't paid a lot of attention, enough attention to quality housing. We have far too many people who are living in substandard housing. We have far too many people living on the street in our nation. There have been efforts, particularly with groups like our veterans, to try to deal with the veteran homeless problem. There's been cities and states that have tried to begin addressing specifically their homeless population. But it's going to require some effort. It's going to require a lot of effort to have quality housing. I marveled, and I want to give him credit, of Peter Bielenson when he was the health officer in Baltimore City. And some of you may remember, particularly those of you faculty that may remember this process, where the city wanted to deal with the lead problem in the city. And we had really not done a good job of trying to address lead poisoning. What we basically were doing, we would abate a few kids. We do a lot of screening. We would bring down the lead levels in these kids, and we put them back in the same properties, or they would move and they go to another property where they got lead exposed. And the city put up a map and said, took little red pins and put all the places where they knew there was lead in those homes. And then they enforced the law to make sure that the homeowners were responsible for that. And then over time, over about a year and a half, you saw the red pins turn green, where they made a concerted, structured effort to bring down lead exposure in kids and improve the properties those kids were living in. And that was a very, very important effort. And that's the kind of thing that you can do in public health. Again, if you begin thinking about ways to address these things beyond the medical care sector as well. It is important, as I mentioned, to deal with this homelessness issue because people who are homeless don't do well. They don't have a usual source of care. It's a big issue. Homelessness and bankruptcies are big issues in trying to deal with the healthcare needs of a community, and they are truly a public health problem. We know that adaptation to climate change is going to be a big issue. Now, I'm a believer that climate change is real. But even if I wasn't, I believe that big snowstorms and big thunderstorms and rainstorms exist. And so even if I don't believe in the ideology, I would argue that we need to be prepared for the consequence. And our public health system plays an enormous role in addressing this and dealing with communities that are drought. As a health officer, we had to deal with making sure that communities had water that they could drink. When the tornado hit in southern Maryland, we had to deal with the consequences of making sure that people were providing care, they could get their tetanus shots, dealing with the mental health aspects of that terrible tragedy, and a range of other issues around severe weather events. And of course, we've seen this in Hurricane Sandy and Katrina and Rita, what these big storms can do to decimate our communities. Then health is about broad community capacity. You know, having safe communities where you can get out and just go sit when someone's gotten on your last nerve. You know what I'm talking about, right? It's very important to reduce stress. Community resilience is built around this. And every community, no matter how poor, has community resilience. And we just need to gather that up and build on those strengths as we try to build those communities. So I often get asked about measuring this whole idea of population health. And I remind us that our clinical colleagues measure their populations a little differently than they do. They look, if you're a clinician or managed care organization, you manage by the individual patient or groups by disease. We tend to do it that way. Hospitals tend to look at the hospitals within their immediate hospital facilities, sometimes right in their immediate catchment area, the folks they just had at a free health fair, they may definitely view as part of their patient population. And the health plans, of course, look at this as they do with their beneficiaries. The key thing is that the things that they do are generally confined to their sphere of influence and often only dealt with through the medical care sector. They track their diseases and their patients by these diseases, so we count the number of people with heart disease and cancer and stroke as part of our process. And we should do this. Data is important, but that's certainly not enough. And I'd like to argue that why it's not sufficient. So here's an example. So we always look at the number of patients you have in a practice, for example. We know how many people have high blood pressure in your practice. That's a good number to know. It's an interesting statistic. And of course, knowing how many of those folks you've gotten their hypertension under control is a good health outcome that one should measure. The idea is you want to get more and more of those people well controlled. But I got to tell you, the percentage of hypertension in your community with inadequate control that are really outside of your practice is a much better population measure, because I don't care how many people you have in your practice that are well controlled, you don't understand what the denominator is. And I don't know how you can make any kind of clinical decision about how well you're doing unless you know the denominator. As you know, the way we practice clinical care in this country, we could simply be pushing more and more patients who are uncontrolled out of our practice, and our number of controlled patients could be going up, and we could be thinking we're doing a wonderful job, and yet people are all stroked out in the community. So we really have to have this understanding of both what's in our practice and that denominator in order to make this a reasonable effort and be able to craft solutions for both of those populations, your subpopulation as well as the broader population. So I'd like to argue what would happen if we took a broader population-based approach. So this is one of my fictional case studies. And that means us thinking broader again and thinking across some of those other dimensions that are important. And I think most importantly, again, thinking about involving actors beyond the healthcare sector. So here's the example. Obviously, asthma is a very common environmentally sensitive condition. It's a big deal because we know that one of the two reasons kids don't go to school as often as they should is access to dental care and asthma. These are two big reasons that affect school attendance. Obviously, you need to understand, and when you go to your doctor always asks, what do you think the trigger was, et cetera, why you had your asthma attack. But we need to know the root cause and do a better job of grabbing those social determinants, again, as I said, to craft broader solutions. So let's imagine 4 different providers. Each of those providers on a given day has a relatively small number of patients. So provider A has 1 and provider B has 3. You notice that each of those providers, those patients have a different insurer that's providing them their coverage. And every one of those providers see this as a relatively small number of patients, and nothing raises a red flag. But they're all in the same community, and in effect, on a given day at a particular school, we have 10 poorly controlled cases of asthma for which those kids didn't go to school. So fantasize with me a system which notifies the health department that today we had 10 kids with asthma who were sick enough and couldn't come to school. Well, we did the epidemiologic investigation just as we would have done had they all walked in with Ebola. We found that all the kids went to the same school, of course, and that there was variance in where they lived, and because the trigger was that they didn't come to school on the same day, there was no really single provider issue here. When you looked at the providers, they had all had pretty good medical care. Insurance wasn't a barrier to them receiving care. But again, nobody would have picked it up unless the health department had done an epi investigation. And in doing that investigation, we discovered that all the kids ride on the same bus. And the bus has a broken tailpipe. So broken tailpipe, a bunch of kids on the bus, asthma attacks. And that's a very common scenario, frankly, that needs to be addressed. And of course, the solution to that really ain't the doctor, it's the bus mechanic. It's the bus mechanic. In addition, the bus mechanic goes out and looks at all the other buses and realizes that there's several other buses that have a broken tailpipe. And if this is done right, and if you do that through a variety of sectors, you'll find dramatic reductions in healthcare costs, dramatic reductions in healthcare utilization. And quite frankly, this doesn't cost a lot more money because basically you got people just doing the jobs that they should be doing each and every day. We've just linked the systems together so they talk to one another. All right? We've shared the information in a way that's meaningful in a real-time environment. I mean, one of our challenges from our population-based work is that we're always trying to manage in the rear. All right? Infant mortality. I don't want to be too crass, but the babies are deceased. We know they have deceased. Why does it take us 3 years to come up with an infant mortality report from the year before? I mean, for 3 years before. Why does it take us 3 years to pull that data together? okay? I can tell you that if you go to a giant food store down the street, they can tell you what's on their shelf and where it is the moment it's been scanned by the customer. They don't have the data problems that we have. We have enormous data problems, and we keep complaining that the systems are not in place for us to do that. I can tell you that every one of you who has a smartphone, whatever marketing company has your name and number from your smartphone, knows everything there is to know about you the minute you push the button. And yet, if I needed to have my EKG, if I got sick and sent across the street from one provider to another, we still haven't convincingly and in a timely way created the data systems to move that information from place to place. And then trying to find what the social determinant was that was a major contributor to my getting sick is not linked to that at all for a variety of reasons. We've got to change, and that's going to be very important as we go forward. So I would argue that our health system has both an opportunity and a challenge, and that we're at a significant crossroad. We've had, success for individuals. Right now, we can, as I say, we can make us better. We can fix it much better than we had yesterday. We can put little cuts in people and put things in them to try to improve their joints, fix their joints, put stents in their hearts. We do amazing stuff on the clinical side. The health reform that we have in front of us, while certainly not perfect, and I can tell you absolutely not the plan that I would have put in place if I could be king of the world for a day, and we're working on that. But it is an opportunity for us to do real transformation. I think we have an enormous opportunity to integrate population health into our healthcare system in ways we haven't done before. It also means that we need to restructure our public health system for it to be effective. I think in three broad areas. One, in places where they do a lot of clinical care, a lot of our health departments are going to get out of the clinical care business. That's going to go to the private sector. But they can't deal with adjustments in terms of the specialized services. There are many places where the health department clinically provides the best service. Some of our STD services, some of our TB services, as an example, some of our substance abuse services, particularly for people with chronically and persistently ill problems, for mental health or substance abuse. The health department has always been the go-to place and probably will continue to be the go-to place. We didn't figure out how to link them in a population way to the broader systems so that those systems are seamless. And ultimately, they become the provider of choice, and we would reimburse them as we reimburse others, either on a capitated basis or on a fee-for-service basis, although I understand we're trying to get out of the fee-for-service movement, and providing a range of wraparound services that are enabling to help people in all of our systems get the care. Trying to find ways to integrate them into our new service models, the accountable care organizations, medical home models, all those kind of things are going to be important. And the health department can provide the social determinants and clinical services as the broker for the rest of government, provide those services, thinking about how to link that to places like education as that model, that case study I pointed out shows. Then certainly being a data consolidator and analyzer, being able to not only give you back the number of your people in your population, of your patient panel that has high blood pressure and whether they're controlled or not, but also help to give you back what the denominator is, to help you analyze that in a meaningful way. I think that would be an enormously important role for our public health system as we go forward. So some of you may know this young woman. And this is Moms Mabley, and she is really the dean of comedians. Almost everybody who's a really good comedian today goes back and talks about how her work has inspired them. I have to admit that most of what Mom said could not be said in polite company, and that was one of her true gifts. But this is something that she did say. I got to tell you that I believe. And of course, if you always do what you always did, then you always get what you always got. And our healthcare system was perfectly designed to get what we're getting today, unless we have enormous change and move, I believe, very much upstream to a population-based approach. We're going to always get what we always got, and we're going to continue to die sooner at a much higher cost. I often get asked what it takes for us to become the healthiest nation. And I've said that a culture of health means living as long as you can, as well as you can, and have a short but glorious ending. But it also means that you have to have a system in place that ensures we can all achieve it. And I think that's an important message, take-home message, I think, for all of us as we go forward, that we really need to design the system of the future. I think public health plays an enormous role in us doing that. Those of you who are students, you will learn as much as you can. Those of you who are in academics, you need to study as much as you can. And those of us in policy need to transfer that and translate that into solid policy. And those of us who are at APHA and other troublemakers like myself need to raise the visibility of these issues each and every day, as loud as we can, as often as we can, until we get this glorious future. With that, I'll stop, and I'll be happy to take any questions that you might have. And let me acknowledge my good friend, David. David, good to see you. Thank you for being here.
Are there any questions for Dr. Benjamin? Do we have a microphone? Yes.
Thank you for the presentation, Dr. Benjamin. Jacoby, you know me, former chair, environment section, APHA. So you presented a lot of slides on the built environment, planning and zoning. I just did a lecture in my Maya 600 class, which is the MPH class for all students and MPH students on the built environment.
Yep.
We talked a lot about the history of planning in the U.S., sort of the separation of planning and public health after the sanitation movement in the U.S. We talked about, disinvestment, divestment. We talked about issues of segregation, gentrification. We really talked about how, looking at our communities as ecosystems and what are the different features of those ecosystems we need to make that organism and the community as an organism healthy. We talked about food apartheid, food deserts, food swamps, food savannas. We got into these issues, and really what the students heard and what we got into is really about how disparities are sort of embedded in this system as well. And so for me, the question is, how do you have an integrated system of planning, zoning, development? You mentioned what APHA is doing with the American Planning Association. We also have, Office of Sustainability in Baltimore, Office of Sustainability in DC. But to me, many of those programs, the connectivity between them, they're not happening. And so as it relates to the tracking of the impact, we don't really know that those policies and programs are actually working. And when you get to the issues of disparities, that's really important for communities who don't have access, communities who don't have good housing, communities who don't have transportation, communities that basically use to host, environmental hazards on some of these locally unwanted land uses. So what can we really do? The new challenge for me is we should be looking at really the integration of these systems and going back, basically old school planning. We need to have old school planning. The Department of Health should be talking to the Department of Environmental Resources in Prince George's County, right? That should be integrated. The State Department of Planning should be working with the State Department of Health and Mental Hygiene. So how can we know what the problems are.
Sure. Well, let me tell you how we can get there. So let me point out, thank you very much, Jacoby. Let me remind everyone that this is the 50th anniversary of the Heckler-Malone report. Does everybody know who that is? Anyone who doesn't know what the Heckler-Malone report is? Okay. It was issued by the Office of Minority Health. Margaret Heckler was the secretary at the time. Tom Malone was the person who chaired the task force. It was a multidisciplinary task force which put out for the first time a from our federal government, a comprehensive report on the issue around health disparities in the United States. And we've been working in many ways off that blueprint for 50 years, trying to address health disparities. One of the key things in that report was the things that Jacoby talked about, was the lack of working across systems, not only just a matter of dealing with disparities, but improving overall health. So we now have Healthy People Now 2020. We now have a set of goals and targets that the nation is working towards. And I think one of the most important provisions in the Affordable Care Act, which I think gets to that point, is the Health Promotion Disease Prevention Council, which is chaired by the United States Surgeon General. And they have begun doing exactly that, putting together at cabinet level agency heads from housing and Treasury and HHS and Department of Labor, Department of Transportation, the Drug Czar's office. All of those groups are meeting with regularity, trying to make sure that what used to happen, where Agency A would put out a regulation which in effect negated Agency B, so that we're all kind of marching in the same direction, that they're leveraging each other's opportunities. We're seeing that. It certainly started. The Bush administration gets credit for doing some of this. The Obama administration, I got to tell you, has stepped it up to a new level to do more and more of this stuff. We saw a great example of this, and let me just give the president credit. Some of you may know that we actually got a presidential proclamation for Public Health Week. This is not something they do every day. You may not realize, I get a letter every year signed by the president saying how wonderful APHA is in National Public Health Week. But he actually proclaimed this week officially, as they say, according to the Constitution and everything else, and I have his signature, that this is National Public Health Week. But then he walked the talk. And he had a meeting over at Howard University where they talked about the health effects of climate change. And the meeting included the president, the EPA administrator, and the Surgeon General. Again, both of them talking through the health lens around the importance of climate change. And we're going to see more and more of that as we go out. We know that when we looked at the climate impact plan that they just rolled out, I think today, there's all kinds of things there where we can now begin to talk about the linkage between our environmental policy, how we're building our communities, what the health impact of that is, transportation. So we're beginning to see that at the national level. Here at the state of Maryland, we have legislation that I think has been signed yet, Olivia?
Not yet.
Around some of the health impacts. So we've got stuff going in Maryland that's looking very much at how we can improve things in a much more holistic way here in our state. And so it's happening. Is it happening fast enough? Of course not fast enough for me. But we're seeing that, that kind of thing happening. Our meeting at APHA is around health and all policies, and our purpose of having that health and all policies framework is to foster that kind of interaction to get people in the meetings. And, you know, far too many times we have meetings like this. This is a wonderful meeting, but look who's in the room. We need to have the Sheriff's Department here, the Transportation Department here. I'm sure that's just a matter of marketing and trying to get them in the room, adding some things on the program. But the more we work and play well together, the more often we're going to see those kinds of solutions occur in our communities. So I applaud your question. I do think there are efforts occurring at the national level, even here at the state level, but we need to push our elected leaders and policymakers more, and we got to make sure they put the dollar behind it, because, you know, policy doesn't happen without money. There's a couple questions over there. He's going to get it. I'll come to you, sir.
Stephen Thomas. I'm a professor here in the Department of Health Services Administration. I direct the Maryland Center for Health Equity. I want to thank you for your presentation, and simply say that I'm disturbed. It disturbed me to hear you describe what happens to you when you walk into a store. It disturbs me to know that Jacoby Wilson and I might face the same thing depending on what we're wearing. And so with all the different policy structures...
Sometimes it happens even when I'm in my suit.
There you go.
But it's off the rack, so I understand why they do it. Yeah.
So you talk about this space right here, and some might say you're speaking to the choir, but you know what? Even choirs need practice. And I think we need real practice about talking about issues of race and issues of racial bias across our different ethnic racial differences in this room, so that we can sing off the same page. Do you believe that this unconscious bias will be solved by online cultural competence training? What ultimately should we be doing to address that part of the challenge that we face today?
Yeah, we need to do a better job of talking about it in a way that people don't automatically clam up and run for cover. I believe it's so much in it that just this month, some of you may know Kamara Jones, who is our incoming president of APHA. Her area is racism and discrimination. I actually have her coming to our staff at APHA because I thought it was important that we start internally to begin talking about this issue. She's going to come to us and talk to us about racism and discrimination. She actually has a very, as you know, her farmer's tale, or her gardener's tale, I guess it's called, has an amazing way to tell that story that's not very threatening to people. And so I have her coming in, and we're going to begin doing more and more of that, trying to talk a bit about this linkage around that. We all have to look inside ourselves, and we have to stop being afraid to do so. We all have biases, okay? We all have biases. We're walking down a dark alley, and somebody walks behind us, however our framing is, who we think is threatening, we're going to feel threatened. They may not be threatening at all, but we feel that way, and that's based on, our life experiences. But we have to have those conversations, and we have to really understand where the real threats are, and that's got to be data-driven and open and transparent. And you're right, we got to have those conversations. Sir. One second, Larry. Let me get the mic so that.
I'm Larry Hobbs. I'm here with a friend from FDA. It's a great program you got all set up. The only thing missing is where is the money going to come from? I mean, personally, I think if the government could provide it, which has become a big problem, they're running short of money. The problem is finding the money for it. My friend Dr. Ben Carson from Johns Hopkins University, they're talking to him to get to run for president. He has a new program for healthcare system, how to pay for the healthcare system, besides using the what we're using now, Medicare, Medicaid, that kind of thing.
Okay.
Where are we going to get the money for all this? It's a great idea. I think that you put a lot of work and effort into improving health, but
sure. Well, let me say a couple of things. So first of all, this country pays for what it wants to pay for, $10 billion a month for a war that we didn't need. So we can figure that one out. But let me just talk about the fact that the Affordable Care Act the budget numbers just came out, that over the next 10 years, I think it's going to cost us $2.5 trillion less than we thought. We could repurpose that money. Some of it could probably even go to the FDA. There's a big effort now to enhance the Defense Department's budget. Okay. But I suspect we could probably go without at least one B-1 bomber, and we could probably double the public health budget with that one. We spend only about 3% of our healthcare dollar on public health. We could rearrange some of that treatment money so that we're now paying 6%, and we would not even miss it within the healthcare system. So how do you practically do that? So I'm sitting in front of the Maryland State Legislature, and we had all these kids who were in institutions, and our public policy position was to bring those kids from those institutions back to Maryland and put them in community settings here in Maryland, because they were more costly out of state than it cost us in state, and they were further away from their families. Okay? I thought a great public policy move. And the question was, where's the money going to come from? Well, every time we brought one of those kids back from out of state, we took the money and we split the difference. Half went to the general fund and half went to the program. So let's look at the waste, fraud, and abuse in our system, for which we think is 20 to 30% in the healthcare system. And my deal would be, if I save you $1, give me 50 cents to reinvest in programs. It worked for me as a state health officer, and I'm sure it would work for our policymakers as our nation. It does require a little bit more work. You might have to add an accountant or two, but you can do that. We have to become much more efficient in what we do. I'll tell you one more story. So I remember when I was at Walter Reed, I was chief of ER at Walter Reed, and the first time we put computers in for lab tests in the hospital, we computerized the hospital. because there is a phenomenon that occurs in hospitals. Those of you who worked in a clinical setting know that there is a gremlin who comes in the hospital at night who is charged with pulling the lab tests off all the charts. So that right before they have to go to the operating room, you can't find the lab tests. And it's a very, very efficient person who does that, okay? And so they got, in order to not screw up the operating room schedule, what does the house staff do? They reorder the lab tests, okay? Because to go to the lab is too much more work to try to go through the books to try to find the result. So after we put these lab computers in place, one happened to be in the emergency department, we were a very popular place because what would happen is whenever the lab test was lost, they would come to the ER and now they could simply go online and pull up the lab result. Now we killed a few more trees, that's true. But operations didn't get canceled and the world didn't come to an end. Patients were able to be discharged because we understood that the information gap was important to moving our system along, and utilizing that technology made a big difference. So I think that's just a small story, but I can tell you that lab utilization fell dramatically at Walter Reed at the time when I was there when we did that, and efficiency in the hospital went up significantly based on simply being able to have access to those lab tests. So there are lots of efficiency experts that have looked at our system in healthcare and are just scratching their head why we run this system the way we do. So I think there's savings there, but I prefer to steal other people's money. So I prefer to take it out of the Defense Department and other places and have them restructure it to their own healthcare needs or to ours. But I'm greedy.
Hi, Dr. Benjamin. I'm Marcos Pesquera with Adventist Healthcare, Center of Health Equity and Wellness, right in Gaithersburg, your neighbor.
You are?
I have a good life expectancy.
See? We're fine.
That's right. We're fine, right? How about the rest of the world? My question is, with all the requirements on hospitals around population health and all the movement that is going and we're scurrying and running around, what kind of conversations are going at a national level between APHA and AHA around improving the capabilities of public health for hospital practitioners?
Well, we've certainly had some, and I can tell you that the people that actually have been more engaged than we have, although we've been involved, is ASTO and NACHO, state health officers and local health officers. NACHO has been working furiously with the Catholic Health Association, for example, providing them some public health guidance into their work. And as you may know, the Catholic Health Association is light years ahead of all of us in this community benefit concept and how to engage communities. And they're really working very hard to make that happen. Rich Omenstock at the American Hospital Association, who's a very close personal friend, has been very supportive of a lot of those efforts and efforts that we've done around community benefit. They've been, he spoke on a panel with ASTO and NACHO to talk about this issue. I recently got invited down to, I've forgotten the name of another separate hospital group that looks at the community benefit effort, and I was a speaker on that panel, ACHI, yes, and spoke at their meeting on this issue. So there's a lot of collaboration occurring. I think what we need to do is make sure that the first thing we need to do is have the meetings and have those meetings without the lawyers, because the first thing they do is they start throwing HIPAA up in the air. They start throwing all kinds of barriers to this kind of collaboration, worried about antitrust issues. There are antitrust issues involved. There are HIPAA issues involved, but most of the barriers are simply made up and aren't real in my view. It's my view now. And that we can craft systems by understanding that you can exchange medical information between your critical business partners. How you define who your critical business partners is up to you. And so it usually inquires. Now you bring the lawyers in to define MOUs and relationship building legally around critical business partners, so you can share information with deliberation with the patient protections that are essential to have so that patient information doesn't inappropriately get into the wrong hands. So it can be done, but again, you got to design the system that you want. And you got to ask yourself, do we want healthy people coming out the other chute on the other end? And if we want to do that, that means we got to have a system that isn't as revenue driven as we have today. Now, no money, no mission. I understand that. But I would much rather have something that is making money, providing the highest quality people coming out the other end, than have a system that's creating all the money in the world and isn't competitive when it comes to improving health.
I'm Sandra Quinn from the School of Public Health here on campus. And from your vantage point, you've been a public health commissioner, you've been a leader of APHA for more than a decade now, you're a physician. So in the room we have students, we have public health faculty, and we have faculty from other places. So when you think about the next 10 years or 20 years, what do we need to be doing differently in terms of training our students, the people who will be taking over from you and me, you know, over these next 10 years as we start to retire? What should they look like that may be different from how we train them today?
I think they need to be team trained and stop training them in these silos where we train this discipline here, this discipline here, this discipline there, this discipline there. I think they need to become good generalists first before we specialize them in maternal child health and injury and global health, or, you know, pick a discipline. I think that we need to find ways to bring practice faculty on that can actually get tenure as they move through the system because they practice and recognize the value that they bring is as important as the number of NIH grants that they bring. I do a lot of reviewing of academic papers and all kinds of other stuff. And I can tell you that when I review something that says it ain't going to work, I'm usually right, regardless of what, you know, their proposal says. And usually the research ultimately ends up that way. I mean, there's nothing any more valuable than experience. And all the mistakes that I've made, I could write 2 or 3 books on them. So I think that getting people in that have practice experience doesn't take away from the academic part. Maybe we let people go into academics and go out and practice and bring them back and do more academics and then go back out and practice. But we need to have well-rounded faculty that have all those experiences, and they need to be able to progress in their career. Otherwise, they're going to pick one silo or the other because that's what you have to do to do in your career. I think for the students, stop trying to plan out your career to the infinite degree. You don't control it anyway, okay? All right? You don't control it at all. I didn't want to go to medical school, had no interest in medical school, ended up in medical school after deciding I was going to do molecular genetic research. Went to medical school, fell in love with clinical medicine, decided to go into internal medicine because I thought the Army would train me better as an internist than I would get in terms of pediatric training in the Army, but fell in love with emergency medicine and ended up most of my time actually at one point was boarded in both internal medicine and emergency medicine, and spent the first 20 years of my time actually in academic emergency medicine. And did, you know, disasters and terrorism and infectious diseases and stuff as an ER doc. And then was minding my own business one day, and my phone rings. There's a mayor on the other end of the phone saying, "Have I got a job for you?" And I went to work for the city health department as the health commissioner in Washington, D.C. I didn't see it as a public health job. I saw it as the next logical movement in terms of I was a department chair at the city hospital, being the health commissioner in D.C., 2 nursing homes, a bunch of clinics. We had this little public health stuff on the side we had to do as well. Did that for a couple of years, left, went out and practiced emergency medicine for 2.5 years. Minding my own business, my phone rings. And the EMS director who had hired when I left the city health department was now leaving Washington, D.C. as a city health department. And they needed someone to come in and fill on an interim basis while they did a recruitment. There's a backstory to that, but it takes too long to tell. So I went back to D.C. government for about 10 months, 5 months with one mayor, 5 months with the next mayor who came back on board. And then, again, minding my own business. Paris Glendening gets elected as governor. Marty Wasserman gets nominated as secretary. Marty and I worked very closely when he was the Montgomery County health officer, and I was the D.C. health officer. And I got a chance to interview for the job and spent 4 years as a deputy health officer. And then, again, minding my own business, but actually I went seeking a job. I spent 4 years at the health department. I was ready to go do something else. I applied for a job. I got it. I was actually the ASTO, State Health Officers Association Executive Director, for about 72 hours. I got the job, hadn't signed the contract, called the governor's office to let them know I was leaving, and they basically said, I don't think so. Have we got a job for you? And I spent the next 4 years as state health officer. And then I went to APHA. So I didn't do a lot of job interviews. I mean, I did a lot of speaking interviews kind of at the end of the day, talking to political leaders. But I got to tell you that in all those positions, I would argue that it was preparation, readiness, knowing what I didn't want to do that guided my career more than having it all mapped out for me and aggressively seeking each way along the way. And I would argue that when I talk to my colleagues in public health at the senior most levels, almost every one of them has had experiences like that. And so get as smart as you can, as knowledgeable as you can, network as hard as you can, and let nature take its course.